Good morning, dear students. We start lecture, and today's lecture's topic is actual issues of diagnosis and treatment of essential hypertension. This is plan of our lecture. I would like to remind you the main types of hypertension. We stratify patients with arterial hypertension to group of primary or essential or idiopathic hypertension or systemic hypertension. And second group of patients, these are patients with secondary or symptomatic hypertension. The main difference between them, primary or systemic hypertension, this is independent process which is characterized by increased blood pressure, and there are multiple triggering factors, risk factors for essential hypertension. And primary hypertension is more prevalent, with approximately 90 to 95% of all patients with hypertension. As for secondary or symptomatic hypertension, it is less prevalent, approximately 5 to 10%, and this secondary hypertension is related with organic pathology of organs, participating in regulation of blood pressure, such as kidney, heart, adrenal glands, vessels. We at current academic year, we discuss the primary or systemic hypertension. By the way, arterial hypertension, this condition is characterized by increasing of the blood pressure more than 139 and 89 millimeter mercury. Clinical manifestation. What are the typical complaints of patients with hypertension? Some patients can complain of headache, vision disorders, chest pain like angina, fatigue. But on the other hand, the presence of these above-mentioned clinical symptoms cannot guarantee diagnosis of hypertension. And opposite situation, patients without above-mentioned symptoms can be hypertension. So that's why we rely on other objective science, diagnostic science for confirming hypertension. Of course, before objective examination, we ask carefully medical history. We gather information about risk factors of patients, such as hereditary, family history, smoking, presence. We ask information about risk factors such as smoking, increased salt intake, alcohol consumption, sedentary lifestyle, history of erectile dysfunction, sleep history, previous hypertension in pregnancy. Also, we ask carefully information about hypertension-mediated organ damage, cardiovascular diseases, stroke, and renal diseases, etc. During objective examination, we pay attention to body habitus, body structure. We assess weight, we calculate body mass index, assess weight and measure weight and height, and also we measure the waist circumference. Or we try to detect signs of hypertension-mediated organ damage, such as left ventricular hypertrophy. We assess neurological status. We perform a neurological examination and cognitive condition status and other signs. Of course, we perform palpation of peripheral arteries. We measure blood pressure in both arms. At objective examination, we try to perform palpation of peripheral arteries in symmetrical parts, or in both hands, in all extremities. We perform palpation of arteria radialis, arteria femoralis, arteria popliteal, and arteria dorsalis pedis. And we perform auscultation of patients. We assess heart tones, heart sounds, presence or absence of arrhythmias. Of course, we perform auscultation of major vessels, above carotid arteries in order to find out possible murmurs, and we perform auscultation of abdominal region. For example, at this photo, doctor is performing auscultation above arteria renalis. What is the reason of this above mentioned auscultation of vessels? At objective examination, we try to rule out secondary hypertension in spite of low incidence. Less incidence of secondary hypertension. Each patient with increased blood pressure should be suspected to secondary hypertension, and objective examinations aim is to rule out secondary hypertension. The next approach, this is waist circumference measurement. The waist circumference is can be measured by simple centimeters, non-elastic centimeter strip line, and we perform measurement in the middle of distance between 2 points. First point, this is inferior margin of the ribs, and second point, this is the superior border of the iliac crest. And what is the normal level of the waist circumference? The normal levels depends on the sex, female and male, and ethnicity. For example, here cut points for abdominal obesity for European patients and for Asian and Indians and South Asians. Body mass index and waist circumference. So that's why presence of confirming of waist abdominal obesity is also part of objective examination in patients with arterial hypertension. What is the reason of measurement and assessment of waist circumference? The clinical studies, they have confirmed that presence of abdominal obesity, this is significant risk factor for arterial hypertension. That's why we do this measurement in all patients with suspected arterial hypertension. About measurement of blood pressure, there are simple rules, and I hope that you know. Let's look at this patient. We pay attention to patient's position of his body, position of his back. His back is supported. His arm is also supported, and we also put carefully the sphygma manometer, the cuff of the sphygma manometer on the patient's arm, and we pay attention to position of patient's feet. His feet are on the floor. During examination, patient is sitting calm and he's not speaking. Routine workup for evaluation of hypertension patients means assessment of target organs. We should assess all above mentioned hypertension mediated organs because they have very high clinical meaning. For instance, damaging hypertension-mediated organ, heart, damaging of heart is manifested in clinical setting by the left ventricular hypertrophy or by the onset of heart failure or ischemic heart disease. Brain, damaging of the brain can be manifested by chronic and acute clinical situations. Chronic means in the development of encephalopathy, cognitive disorders, acute cases. These are patients with stroke. Most of them, they have ischemic stroke. Hypertension-mediated organ damage of kidney is manifested by nephrosclerosis and subsequent development of renal failure. Vessels, they are manifested by hypertrophy of vessels media and early onset of atherosclerosis of large arteries. By the way, with hypertension patients, they have approximately 10 years earlier onset of atherosclerosis than other general population. Retina is manifested by the retinopathy. For confirming the retinopathy, the patient needs ophthalmological investigation. Assessment of hypertension-mediated organ damage can be performed via instrumental and laboratory tests. In laboratory setting, we refer patients' urine specimen for albumin creatinine ratio. We refer patients' blood sample to blood creatinine, and we calculate the glomerular filtration rate. We check, of course, we perform fundoscopy during ophthalmological investigation. We refer patients to 12-lead ECG. This is necessary for confirming or excluding left ventricular hypertrophy or other possible cardiac abnormalities such as arrhythmias and ischemic changings. Echocardiography is necessary for evaluation of cardiac structure and function. We evaluate cardiac function, and also we can clarify the left ventricular hypertrophy. Carotid ultrasound scanning is necessary for confirming atherosclerotic lesion of carotid arteries. Abdominal ultrasound and Doppler studies, they are useful for evaluation of kidney size first, second for examination of adrenal glands, and next renal artery Doppler studies is helpful for confirming or exclusion of secondary hypertension, renovascular hypertension. Also, we refer patients if necessary, we can refer patients to other screenings, other laboratory instrumental tests. Laboratory tests, we obtain patients' blood sample for assessment of general blood test, CBC test. We assess hemoglobin or hematocrit in order to rule out deep significant anemia. We perform investigation of glucose, glycemia, fasting glycemia, and postprandial glycemia for if you suspect presence of the impaired glucose tolerance or type 2 diabetes. We check, of course, lipids. We do not restrict by investigation by total cholesterol only. We refer patients to lipid spectrum. We assess carefully LDL cholesterol, HDL cholesterol, total cholesterol, triglycerides, electrolytes, potassium, sodium, blood uric acid, blood creatinine, and we calculate GFR. Blood liver function tests and urine analysis are necessary. As for urine analysis, the microscopic examination is usually at the early stage of hypertension, it usually doesn't have significant changes. But for early diagnosis of nephrosclerosis and nephropathy, we refer patients to microalbuminuria tests, and also we refer patients to 12-lead ECG. Ophthalmological examination fundoscopy can assess the vessels, retinal vessels, and here I would like to propose you comparison of fundoscopy in patient without changings of retinal vessels and in patients. It writes for the patients with hyper advanced stage of hypertensive retinopathy, grade 4. We can see several specific signs, diagnostic signs for such as papilla edema, heart exudate, cotton wool spot, symptom of flame hemorrhage, and also we refer patients to other instrumental tests. We assess echocardiography. Echocardiography, this is non-invasive test. This is useful for assessment of heart function and heart anatomical. What can we see at these clinical cases? This is this image provides information about wall thickness of left ventricle. We can see at the middle photo, we can see concentric signs of concentric hypertrophy of the left ventricle. We can see increased thickening of the posterior wall thickness and septal wall thickness. Also, there are diagnostical criteria for diagnostical echocardiographical criteria for left ventricular hypertrophy. These are more than 11 millimeters. So, diagnostical criteria for left ventricular hypertrophy means interventricular septum thickness more than 11 millimeter and left ventricular posterior wall thickness more than 11 millimeters. These are diagnostical criteria of left ventricular hypertrophy. Resting ECG is necessary and mandatory for all patients with hypertension. We check the signs of left ventricular hypertrophy. Left ventricular hypertrophy is for these patients. Left ventricular hypertrophy can be confirmed by a measurement of voltage amplitude, voltage criteria. What are these are deep S wave in right chest lead for such as V1 or V2, and we add R wave amplitude of R wave in left chest leads V5 or V6, and this above mentioned the sum of above mentioned amplitudes exceeds 35 millimeters. This is diagnostic criteria for left ventricular hypertrophy. This is clinical case. Patient has male patient has left ventricular hypertrophy signs. He has history of high blood pressure, and we can see a left strain pattern with ST segment depression and T wave inversion in the first standard lead. It's a AVL lead and also left chest leads V5 and V6. Also there is evidence of left axis deviation. Look at standard leads. Moreover, I would like to pay your attention to amplitude of R amplitude criteria, amplitude of R wave. It's AVL lead exceeds 11 millimeter. This is diagnostic criteria. This is additional diagnostic criteria for left ventricular hypertrophy. Also, the most this is also criteria, diagnostic criteria of left ventricular hypertrophy. This is other clinical case, patient with hypertension, and we can see voltage, positive voltage criteria of left ventricular hypertrophy. This patient has increased R wave, tall waves, R waves in the V5 and especially V6, and deep S wave in the V1 and V2, and left axis deviation in standard leads. Blood pressure monitor, measurement of blood pressure is this procedure should be performed at home setting also, because because most of some patients, they can get nervous at the hospital, at outpatient hospital setting. That's why we recommend current time the measurement of blood pressure at home setting is recommended by recent clinical guidelines from European Society of Cardiology and American Heart Association, and also European Society of Arterial Hypertension. There are several advantages of home blood pressure monitoring. First of all, we can identify or rule out white coat and masked hypertension. This is widely available for patients, most of patients, and also measurement at home setting is useful because patients at home, they usually feel relaxed compared with doctor's office. And we engage patients to measure their blood pressure at home because it can increase the compliance of patients for subsequent treatment. And this procedure, this is non-invasive test, it can be repeated and assessed day to day. We can evaluate the blood pressure variability. Disadvantage, of course, only static blood pressure is available. Potential for measurement errors because patients they can misunderstood the rules of measurement of blood pressure, and impossible to obtain information about nocturnal levels of the blood pressure. That's why in such patients, if you would like to assess nocturnal level of the blood pressure, we refer them to ambulatory blood pressure monitoring. This is also non-invasive test. It can also help to identify white coat and masked hypertension. Compared with home blood pressure monitoring, the ambulatory blood pressure monitoring, it has more stronger, highest prognostic evidence. Also, the advantage is we can obtain information about nocturnal readings of blood pressure. We can evaluate the 24 hours blood pressure variability. And measurement is done during real life setting. Patient can do their ordinary daily activity. Disadvantage, it is of course more expensive and sometimes can limit availability, and sometimes can be uncomfortable because this equipment performs automatically measurement of blood pressure each 15 minutes at the daytime and each 30 minutes at night time. For comfortable measurement, we should adjust the size of cuff, sphygmomanometers cuff to patient's shoulder, and we try to explain patients the rules of this measurement. And by the way, classification of high blood pressure according European Society of Cardiology and European Society of Hypertension guidelines, is recent guidelines, is the classification of high blood pressure is presented at this table. We stratify patients with high blood pressure to grade 1 hypertension, grade 2 and grade 3 hypertension according to the levels of the systolic and diastolic blood pressure. Most of students ask me a question about patients with different levels of systolic and diastolic blood pressure. For example, patients with systolic blood pressure which corresponds to grade 1, but diastolic blood pressure which corresponds to grade 2 hypertension, we take into account the highest level of the blood pressure. For example, patient's blood pressure 140 by 100, we put diagnose grade 2 hypertension. Or opposite situation, patient with blood pressure 160 by 90, we put diagnose grade 2. Or also there is the additional group of patients with isolated systolic hypertension. Isolated systolic hypertension definition, this is a condition where the systolic blood pressure is 140 and more, but diastolic blood pressure is less than 90. Here we put diagnose isolated systolic hypertension. Management of patients with high blood pressure, essential hypertension means the using of several approaches, non-medication and pharmacotherapy. Non-medication approach include correction of risk factors, cardiovascular risk factors. For example, recommend to quit smoking or stop alcohol, taking alcohol, or reduce salt consumption, etc. Second, non-pharmacological approach. This is education of patients. This is highly important because recent clinical studies, they have proved that education of patients can increase the compliance for treatment. And the third approach, this is pharmacotherapy. As for the steps of treatment, we use step-by-step approach. Step number 1, we assess cardiovascular risk factors. Second step, we assess hypertension-mediated organ damage. And third step, we detect target levels of the blood pressure, target levels of blood pressure in different patients. As for non-pharmacological approach, salt restriction, we recommend this salt restriction to all patients with hypertension, and this recommendation has been confirmed by large clinical studies, randomized clinical studies and meta-analysis of randomized clinical studies. The blood pressure lowering effect of sodium restriction is greater in some specific groups of patients, such as Afro-Americans, Black race, in older patients, and in patients with diabetes, metabolic syndrome, or chronic kidney disease. Excessive sodium consumption, more than 5 grams per day, has a pressure effect, and this condition is associated with an increased prevalence of hypertension and the rise in systolic blood pressure with age. And conversely, sodium restriction has been shown to have blood pressure lowering effect. Initiation of blood pressure lowering treatment, lifestyle changes and medications at different initial office blood pressure levels is presented at this slide. We take into account levels of the degree of increased blood pressure, for example, grade 1, grade 2, or grade 3 first. Second, we take into account presence or absence of hypertension mediated organ damage, and also we take into account presence or absence cardiovascular disease, and the management of patients, of course, pharmacotherapy of every patient, every group of patients. They start with counseling, with we use lifestyle advice, and then we prescribe medications. Patients with grade 1, starting with grade 1 hypertension, all patients with hypertension starting with grade 1, grade 2, and grade 3, they need pharmacotherapy, especially in patients with cardiovascular disease, renal disease, or hypertension-mediated organ damage, or patients with very high risk of cardiovascular complications. That's why even in even in grade 1 hypertension, we prescribe pharmacotherapy. What about the targets of blood pressure? It is mandatory to achieve and maintain target level of blood pressure. What are the targets of blood pressure in patients with hypertension? We stratify patients by their age, younger than 65 and older than 64 years. Patients with who are younger subgroup of patients, we try to achieve and maintain systolic blood pressure from 120 up to 129, diastolic less than 80. more older group of patients, we can use target level of systolic 130 by 130 from 130 up to 139. The diastolic target is the same for both groups of patients. Also, we take into account patient tolerance of treatment, tolerance of this target levels of blood pressure. Patients with who tolerated who has lower toleration of low blood pressure, we maintain blood pressure systolic 120, but not less than 120. As for blood pressure lowering drugs, we prescribe, we have 7 subgroups of hypertensive, antihypertensive medications, but these medications, they have different clinical meanings in clinical setting. The most frequent used medications, the first choice medications, drugs for treatment of hypertension, these are 3 groups of medication. First, diuretic, second, RAS inhibitors, and third is calcium channel blockers. Of course, we can use also beta blockers, but in specific group of patients, in patients with coronary heart disease or heart failure or tachyarrhythmias. As for other subgroups, imidazoline receptor agonists, moxonidine and alpha blockers, doxazazine, they have less meaning in clinical setting due to side effects. And these above mentioned distribution of stratification of hypotensive drugs was proposed by recent updated clinical guidelines by European Society of Atherosclerosis. Which medications are the first line drugs? We prescribe initial therapy. We start initial pharmacotherapy by the RAS inhibitors. By the way, RAS inhibitors means angiotensin converting enzyme inhibitors or sartans. We use sartans for medication angiotensin receptor 2 blockers. We do not prescribe these drugs simultaneously. The first choice, this is AC inhibitors. Angiotensin receptor 2 blockers, they can be prescribed as a second choice. They can replace AC inhibitors in patients who cannot tolerate AC inhibitors, for example, due to dry cough or angioneurotic edema. Initial therapy, we start with RAS inhibitors or calcium channel blockers or diuretics. But patients, most of patients, they have high risk of complications, and that's why in high risk patients, we use combination of 2 medications. First of them must be RAS inhibitor. Second, the drug can be calcium channel blocker or diuretic. Step number 2, we use triple combination. We use 3 above mentioned medications: diuretic, calcium channel blocker, and one of RAS inhibitor, usually ACE inhibitor. The next step, this is the treatment of resistant hypertension. What is the definition of resistant hypertension? Resistant hypertension is a condition where patient's blood pressure cannot be decreased enough unless in spite of using of 3 antihypertensive medication. One of them is diuretic. A few words about beta blockers. Beta blockers, they are valuable and useful medications but for some specific groups of patients with hypertension. We consider beta blockers at their initial treatment of arterial hypertension in specific groups of patients with concomitant presence of the concomitant heart failure, angina, patients with post-acute myocardial infarction, patients with atrial fibrillation, is tachy form of atrial fibrillation, or in younger women with or planning pregnancy. By the way, RAS inhibitors, they are strongly contraindicated for fertile women. Single pill combination. Single pill combination, current time, this strategy has been recommended by recent clinical guidelines, and this strategy has been proved in clinical studies. What is the main principle of single pill combination? Patients, most of patients, they need combination of several antihypertensive medications, but the main question is patients' compliance. In order to increase compliance of patients, we use single pill combination, fixed combination of two drugs. For example, this tablet, white and red colored tablet, it contains two medications. For instance, ACE inhibitor, white colored, and calcium channel blocker, red colored. But from patient's point of view, he's using only one tablet, only one drug. Patients, they usually focus their attention on the number of tablets, not number of medications. That's why single pill treatment strategy for hypertension, this is more preferred for long-term antihypertension therapy, and the single pill combination has less prevalence of side effects. Let's make conclusion. Patients with essential hypertension have an increased risk of cardiovascular complications. Next conclusion, hypertension-mediated organ damage remains the leading cause of death from cardiovascular disease, disability, and poor quality of life. Patients with essential hypertension, they need lifelong antihypertension therapy, and pharmacotherapy includes the most possible drugs, the drugs of first choice. These are RAS inhibitors, ACE inhibitors, and angiotensin receptor 2 blockers. These are calcium channel blockers and diuretics. This is the list of literature I have used for preparing for current presentation. Thank you very much for attention. We have finished our lectures. Ask your questions.